Hi everyone, my name is William. Today I'm going to be presenting with my partner, me, about azithromycin use and prevention of acute exacerbation in COPD patients. So according to CDC, approximately 27.6 million azithromycin prescriptions were dispensed for patients in outpatient and inpatient according to the 2020 data. Azithromycin is the second most commonly antibiotic use, and the mechanism of action for this medication is that it works by binding to the 50th ribosomal subunit of the bacteria in order to inhibit the protein synthesis to prevent the bacteria from further replicating. And so azithromycin is also part of a drug class called macrolides. And some of the FDA approved indications are treatment for acute bacterial exacerbation for COPD and community acquired pneumonia. So some of the most common side effects for azithromycin can be diarrhea and loose stools. Some of the less common side effects for azithromycin can be blistering, irritation, itching, reddening of the skin. It can also be cracked, dry, or scaly skinned, and fever. And some of the rare side effects or serious side effects for azithromycin are peeling or loosening of the skin, bloody or cloudy urine, bloody, black, or tarry stools, congestion, chest pain or tightness, and chills. So, acute exacerbation in COPD patients usually indicates the continuous worsening of a patient's COPD health condition, which may further require additional therapy for these patients to treat the underlying cause of acute exacerbation. And acute exacerbation can be triggered by bacterial or viral infections or environmental stresses in COPD patients. And so the three most common bacterial pathogens that are found to cause acute exacerbation in COPD patients are non-typable Haemophilus influenzae, Moraxella cardialis, Streptococcus pneumoniae.
Next, I'm going to talk about some of the evidence supporting the use of azithromycin for acute exacerbations. In 2011, a large trial by Albert and also some of the small trial showed that the use of daily azithromycin would help to decrease the frequency of exacerbations, the number of hospitalization, urgent care, unscheduled visits, intubations, and also the incidence of colonization with selected respiratory pathogen. And it also helped to improve the quality of life in patients with COPD. In 2013, a Cochrane review, including 7 studies, supported continuous prophylactic macrolide therapy for the reduction of acute exacerbation of COPD. In 2014, a trial by Phan identified azithromycin to be more effective in the elder population and also patients experiencing mild severity of acute exacerbation. And lastly, the Columbus trial in 2014 demonstrated that taking azithromycin 3 times weekly could significantly reduce the rate of exacerbation. Some of the drawbacks of azithromycin use in patients with COPD could be the increase in the incidence of hearing decrement. However, the hearing decrements were resolved in 1/3 of the patient while they continue to take azithromycin. So it is very unlikely that this effect would be permanent. The long-term use of azithromycin can potentially lead to cardiovascular toxicity such as QTc prolongation, myocardial infarctions, and cardiovascular death. It also associated with the development of macrolide resistance. And last but not least, azithromycin is not effective in patients who are actively smoking. The current use of azithromycin in the prevention of exacerbation could be 250 to 500 milligram 3 times weekly, 250 milligram once daily. And azithromycin could be considered in patients with frequent exacerbation despite optimal medical management more than 3 exacerbations per year, at least one of those require hospital admission. Azithromycin for 1 year would have to reduce the risk of exacerbation and also improve the quality of life. For the long-term azithromycin therapy, the physicians must weigh the risk and the benefits because it would increase the incidence of reversible hearing decrement, QTC prolongation, and bacterial resistance. And according to the GOLD report, there is no benefit past 1 year of treatment. Okay. That's everything that we would like to talk about today. Please let either William or I know if you have any questions. Thank you for listening.
Thank you for listening.